Welcome back, Health Impact audience. We're going to have a special session today talking about a very specific set of audiences that a lot of us should really be building technologies, service lines, et cetera, for, but we don't really discuss it in the same way that we probably should. So we've got a couple of experts here who understand this market of connected or even disconnected seniors, right? So we're going to talk about hybrid healthcare and how it applies for telehealth, remote patient monitoring, smart devices, et cetera, but for a very specific audience, and that is the seniors, whether they're aging in place or they're going to nursing homes, et cetera. And why talk about a very specific audience? It's because technology gets better when the audience is narrow and very specific to particular demographics. Now, why pick the seniors as opposed to the pediatrics, et cetera? It's not one versus the other, but what we've learned is that it turns out that if you make the technology useful and easier to use for seniors, it trickles down. There's a good trickle down effect for the tech, is that if you can nudge a senior, if you can get an app to be used by a senior, it's very likely that it can also be used by others. So it's a nice area for us to focus on. And I always like just targeting a very specific demographic because as a software engineer, it helps us build faster and better anyway. So with that, let me let Ramala introduce herself, and then Eric will introduce himself, and then we'll jump into our questions for this topic.
Ramala, hi, everyone. My name is Ramala Batra. I am the Chief Medical Officer at Scan Health Plan. I'm a primary care physician by background. And for those of you who do not know Scan Health Plan, we are a not-for-profit Medicare managed care plan based out of California. We serve about 225,000 members. Most of them are older adults that Shahid just spoke about. We also are very proud of our roots. Our roots are based in the community, and it was founded by 12 angry seniors who said that we want more to health than just doctors and medicines. And so here we are, being the longest serving social managed care plan in the CMS history. We are also a 4.5-star plan, so proud of what we have achieved in terms of quality. And last but not the least, and I'll leave you with that, Shahid, and at Scan, we totally believe in high touch, not low touch, but the right touch at the right time for the right people. So very excited to be talking about this topic today.
Awesome. Welcome, Ramala. Welcome. Eric?
Hi, everyone. So I'm Eric Lee, Medical Director of Clinical Informatics at Ultimate Health Services. I've been with Ultimate for a little over 2.5 years, and a little bit about Ultimate Health Services. We're, I believe, California's largest federally qualified health center and one of the nation's largest. We serve over 300,000 patients in both Los Angeles and Orange counties across greater than 35 different sites. We also have the nation's third largest PACE program, or Program for All-Inclusive Care of the Elderly. And we have a patient mix of where greater than 90% of our patients are managed Medi-Cal, at which 2/3 live at or below the poverty level. So we have some unique challenges as well, and I'm excited to be with you guys today.
Awesome. No, welcome, Eric. So Ramala, we'll start with you. What do you feel? And I love that example you gave of the 12 angry seniors that started Scan in the first place. What is it about those 12 angry seniors that we can use as a template to say, you know what, post-COVID, in the middle of COVID and then post-COVID, what should service lines and healthcare services designed for healthcare elderly, what would that look like? And in the hybrid world, you have all this new tech, new capabilities, et cetera. How much should that play a part? Because seniors are demanding it, not because we think it's a cool thing to do, but because seniors themselves are demanding those kinds of hybrid services.
Oh, no, I absolutely agree. And for us at Scan, what we have decided is we are going to make some wise choices and create a new normal. Let's leave the old normal behind and let's create a new normal. And in the new normal, care should be provided to the people the way they wanted, where they wanted, and how they wanted. So no more of the brick and mortar, you come to us, a very provider-centric care, but more of this is how I want my care. I am the member here. So we are designing for that. And as we are designing for that, we work in a work group called Office Visit is a Dinosaur. We have created a work group around that to say, well, does it mean we just retrofit our workflows, or we really truly go from a member's journey? And so we have created journeys around that. And one of the myths, we were talking about myths right before the session, Shahid. One of the myths is, older adults will not use technology. And that myth has absolutely been busted during the last 1 year. And so if we look at it, our average age is 74 of the population that we serve. When I share our telehealth experience in the last year, totally busted. 50% of the visits last year in the second quarter were around video visits and telehealth visits, which we would have never fathomed in the year before that. So people are wanting to access their doctor, their nurse, their social worker, their case manager, their physical therapist by using these kind of technologies. And so it behooves us to not only offer them the care that is to be delivered that way, but also close the digital device and folks who may not have that access to technology, but still want that kind of care. So we are broaching it from how do we increase the adoption, provide care as people want it, those who have access to that care. And for those who don't have it and have the digital divide because they don't have broadband, which I think broadband and Wi-Fi access should be the biggest social determinant of health known to mankind. How do we get care to them? So we'll talk more about it, and I'll share what we're thinking about it.
No, that's great advice. And when you think about the fact that, over 50% of them accepted this over the last year, do you get the sense that that was their fear of being infected with COVID and that's why they chose this and ultimately they don't really want it? Or do you feel like, no, they're only accepting it now because we offered it in ways that was easy for them to access? Where do you fit in that? And it's opinion, I understand, because you don't have all the data necessarily, but if you have some thoughts, I'd love to hear that.
Yeah, so I think in the beginning, so if you looked at the months of April and May, there was a little bit of, oh my God, I don't want to get infected. And guess what? I had no idea I could access care that way. Because let's be honest here, folks, the providers were also not ready to deliver care in that way. And the reason they were not ready, I'm a primary care physician by background, because there were so many legal requirements and compliance requirements and reimbursement requirements. And so when we threw that kind of out of the door with relaxation of some of the regulation, providers started offering that kind of a video care, and patients wanted, our members wanted that kind of care, so they started accepting it. But let's march forward. So in quarter two, as I said, we saw about 50% of our visits were video visits. And, we're in California, so we had a big impact of the pandemic. But what we noticed even over the course of next few months is even though they started going down as, clinics started opening, people started re-engaging with care. But one more time, it looks like it's going to settle down somewhere between 20 and 30%. So it's not going to go away. And it's not going to go away because people are now liking this kind of an engagement. And as a provider, what I hear from my provider partner friends is, it's a different view. We talk about social determinants of health, but when a patient walks into my office, they look very well put together, very well dressed, and I take it for their base word. But when I am talking to them over video, I can see the background. I can see, where their medications are. It gives me a little bit different look to where they live, how do they engage with care, what perhaps their home environment looks like, especially in the older adults. So I think it's here to stay.
Got it. Eric, so just, piggyback on what Ramala was mentioning, and you can certainly add some color to her comments, but I would love to hear from from your perspective, what is the institution doing that might be different than you would be doing if you weren't focusing on seniors? So what I'd love to do in this conversation is, what could we learn from seniors and how they approach technology, how they make decisions, that then we can say, you know what, this makes sense. I can now trickle this down to others in, the 50-year-olds and the 30-year-olds and the 20-year-olds, et cetera. So any color comments, and then let's talk about what you're doing that's specific to seniors.
Well, I think, an approach to seniors, you first have to understand where they're coming from. I think they have a different baseline level and comfort with technology than our kids, right? I mean, our kids grew up using iPhones and iPads and download this app and use this, and everything, they can just fly with it, right, at school. Whereas, seniors, they grew up they know how to use a phone, and they're able to dial a 10-digit phone number. And they may need some additional training and reinforcement to be able to do that, right? And I think I was just at my in-laws' house this past weekend because they were having trouble with their Wi-Fi network. And so again, you have to be prepared to be able to provide that support. And I think that's a really important consideration on how you're going to continue to support them and as they go along this journey. But with this pandemic, as Dr. Batra or Romulo has been saying, I think there's really been, this digital divide has really become even more transparent. And with the patients in the zip codes that we serve, I think it's almost a digital desert. I think we had to bridge a gap with telephone visits initially, and while we were getting the video visits up, there were some challenges that we were having, and we have to better understand our seniors. We have to better understand our patients. We have to figure out how to make it more usable for them and to be able to make the significant progress that we need to make, right? So I think I think an example of what we did in this past year to make it more usable and to bring that forward with 2021 was really understanding how are you going to do video visits? Is it going to be a standalone solution? Are you going to integrate it into your electronic health record so that your providers are able to see the patients and access and visit them, and get that insight, like Dr. Butcher was saying, of looking at the patient's homes? You can see that what's going on in the background and gain a deeper understanding of your patient's home situations. And so what we did over this past year was integrate a video visit vendor into our electronic health record and actually complete the full journey so that you're able to pass it off to a mobile device. Providers can work from anywhere, because that's another issue with this pandemic, is you want to have a contactless environment as much as possible. And then lastly, be able to complete that journey with direct text to the patient, so the patient knows when the provider's ready to see them. They're able to get a text message. They're able to open that text message, click on that link, and open up the video visit window. There's no downloading of apps. There's no complicated instructions you have to do. So you really want to simplify things as much as possible so that everyone's at the same baseline level.
Mm-hmm. And expanding on that text part a bit more, so to me, it seems like we're probably not using text as much as we probably should be, because there's definitely the digital desert you're talking about is a great term, and there's certainly a digital divide even in urban settings, et cetera. But what there is not at the moment, a divide between having analog or text-capable devices. Do you guys get the sense, and Eric, I'll let you, because you mentioned it, I'll let you answer first, is what more could you do by text for education and maybe even actual clinical follow-ups, and not be afraid and say, okay, we have to do a video visit or you have to do a phone call? So it should go the following route. Whatever you can do by text, you should do by text. Anything you can't do by text, you do by phone. And then whatever you can't do by phone, you then do on a video visit. And then following that is an app, and we'll get to remote patient monitoring and things like that. But is that the pathway that you see? Because it seems to me that is a natural path for, regardless of what your age is, but especially for the seniors.
Right. I think it has to be what makes the most sense and what's most intuitive and really ease of use. And you always have to look from the patient's perspective, right? I think one of our strategies when rolling out video visits was that we were only asking our patients to download one app at all times, which is our patient portal associated with our EHR. We didn't want them downloading another app to be able to launch a WebEx or a Skype or, and because that gets too complicated, right? And I think you need to have that integration. And so the challenge is on us, right? As healthcare organizations and providers, how can we offer that integrated experience so that when, because that's digital front door, right? What's your website looking like? Do you have a chatbot on there? Does it integrate and feed into your contact center? When you call the contact center, do I know who that patient is, what the key stats that I need to know, upcoming appointment dates and whatnot? How does that integrate to a text message that I sent out to the patient as part of a text campaign that you're now eligible to receive the vaccine? And then how does that response to that text message feedback and allow the senior to be able to schedule an appointment, to come in for an appointment or to schedule their vaccination appointment, right? And so, yeah, but you're crossing text to phone call to patient portal to electronic health record, and that text message should be able to schedule an appointment in your electronic health record, going across all of these different modalities. But that's not the patient's responsibility or the senior's responsibility to navigate, right? But far from it. It should be our responsibility to make sure they're all integrated and talking to each other so that the patient experiences that I can reach my provider and schedule an appointment or visit or in the whatever modality I want to do, whether it's audio only, whether it's video or face-to-face. And I think federal regulations are beginning to relax on this pandemic as you see the curve bending and the numbers improving, and you're beginning to see proposals for audio only visits reimbursement to go away. And I'm like, that's the wrong approach, right? I think you have to be able to address audio only, video, face-to-face. They should all be equivalent, but you need to be able to address it until you have addressed all the barriers, the technological barriers that are standing in our nation's different zip codes. You have to address that first before you're able to talk about removing these sorts of reimbursement issues.
No, that's great advice. And in fact, Ramala, when you think about the nature in which we talk to seniors today, it's almost very episodic, just like it's always been. But there is this idea that you can actually have continuous monitoring through remote patient monitoring, smarter devices, et cetera. Where are you guys feeling and how are you feeling about that kind of thing where, there's a lot, I don't need to keep calling them up. I don't need to keep sending them text messages. If I just give them a darn remote patient monitoring, is that, dream talk, or are you putting some of that into place today? And are you finding some success with remote patient monitoring?
Yeah, we, even before the pandemic, have always looked at things from our members' point of view and being very member-centric, and actually invested even before the pandemic in the digital technology roadmap. So we have a 3-year roadmap in terms of how are our patients and members' views transforming and evolving, and what would they need when. And I do agree with Eric. We want to make sure the right thing to do is also the easiest thing to do, right? So we have folks who still want to talk to my case manager over the phone. They're used to it. They still want to continue doing that. So let's make it available to them. And we have folks who are saying, like my in-laws, like, why do I need to call their contact center? Why can't I chat it out like I chatted out with Amazon? Amazon has spoiled us. So we are trying to meet both needs, especially as people are aging in. The younger agents are more comfortable and they do want that. And I'll give you an example. One of the supplemental benefits that we introduced last year was Fitbit. And people want to not only use the Fitbit, but they want the Fitbit to interact with our member engagement platform. So we have a member engagement platform where you can go in, do your health risk assessment, pick a journey. And so we are looking at all those things to say, not only do we want to make sure we are thinking about remote monitoring on folks that are perhaps have more advanced or complex illness, but even the younger, healthier folks like to have those kind of, wellness vitals right on their fingertips. So yes, we are exploring remote monitoring. We are especially exploring remote monitoring for our members that are polychronic, have multiple complex chronic conditions like heart failure or renal disease, or difficult to control blood pressure or diabetes. And we want to engage with them. I think that's where, as a physician, I'm the first one to raise my hand. I'm like, we cannot give them an app for this, an engagement platform for that, and a health plan portal for this, and Eric's, patient portal for the physician group. That people are going to get confused. They want one-stop shop. So before we start willy-nilly introducing these things, the first and foremost thing is let's make sure they're connected to their providers. And then once we have interoperability, which looks like we are going down that path of interoperability, hallelujah to that, then perhaps, Eric, when they are in your portal, they can get connected to our portal, and that way it's a seamless experience. Or they are in our portal, they get connected to your portal. So those are the things we first want to build while we are managing the care of, the top 5% who perhaps it's difficult for them to leave the house.
Yeah, and in that regard, then, if it seems still like remote patient monitoring is still months out for
yes.
a large population. So you're kind of dabbling. Eric, would you classify yours as still dabbling, or do you have a methodical plan to be connected via remote patient monitoring?
Oh, great question. So yeah, we're live with remote patient monitoring with congestive heart failure patients. I think previous data and existing data shows that it's one of the top 10 conditions in which you can establish some easy or hopefully meaningful outcomes and improve readmission rates, improve quality of life, because less time spent in the hospital is hopefully improved, associated with an improved quality of life because you're at home and able to do the things you enjoy. And so I think it's reinforced education is one of the biggest benefits with a remote patient monitoring, but the tech is easy to roll out, right? It's the little things that you don't think about, right? The people and the processes. So you got to account for our senior population as with what they experience as they're aging, right? So that it may be harder to see. So by default, you got to have a larger font appear to them. It may be harder of hearing. So by default, maybe you have to be able to account for that and have a larger or a higher volume setting. Difficulties with arthritis or plugging in a micro USB cable into a device to charge, right? So how are you going to make it easy for them so that there's only one port with only one cable and there's only one way you could possibly fit in there so I can plug it into the outlet to charge the devices, right? So it's really, again, as Dr. Batra and Scan says, the right touches with them. You got to introduce the right devices. When you deliver it to them, you got to have the right touches in terms of tech support. Let's walk you through this in your preferred language, right? And so we have to make sure we account for, almost half of our patients have a preferred language that's not English. So you got to make sure you provide that support and the orientation of this is how you do this. This is what we want you to do on a daily basis. And then monitor those vital signs and see what we can do to make a difference in improving our seniors' lives.
Now, that guidance was awesome. I think as you start to get down to the very specifics, I think that's why targeting seniors as a technology demographic makes you think about these things and then say, wait a minute, there are probably 50-year-olds or 25-year-olds that also have eyesight issues, that also have hearing issues, et cetera. And so now you can actually put the options in to say, okay, should we make the font bigger, et cetera? And this is why I think the session is really good. We need to teach our designers, like, knuckleheads like me who make software for a living. Hey, did you think about this? Did you think about that? And when you say, let's go build for the seniors, it is literally the hardest ones to build for. And if we get it right there, they can trickle down. So Ramala, if you think about the social isolation problems that have been exacerbated due to a pandemic forcing everybody to be isolated even more, could things like an Amazon Alexa sitting in their house or a Google Home sitting in their house, in which the nudging is occurring in a conversational format, is that worth kind of like doing some quick trials before going through, like one of my biggest fears as a product designer and an entrepreneur is in healthcare, we think about things for a long time and then we want everything to be applicable to all patients, but that's not how design is done, right? If you've got 1% of your patient that can benefit from this, send it out to them. 2% can benefit from this, send it out for them. Is that worth thinking about? So remember we talked about text, conversations through Alexa, apps, et cetera. We always think about telemedicine and apps as the hybrid care, but that's not the hybrid care that would be done in a continuous, everyday manner to help with things like isolation. What are you guys doing on the isolation front?
Yeah, so we are looking at that in our roadmap, but what we have, having done many focus group, many human-centered design work, what we have come to know, and I'll give you context, we did 100,000 plus social outreach calls during the pandemic to check in on our members. And what they really crave for is that human connection. And so what we did was we said, let's leverage technology to build on that human connection. And so we used the plain old iPads. We have a workforce, we call them peer advocates. They're basically our members, so they're older themselves. We gave them the iPads and they are engaging with our members who also have iPads, so they can have that FaceTime-like call, and they love that kind of a human connection. And for those who don't have it, I think, I call that necessity is the mother of invention. We bought iPads. We have a logistics service that now drops off iPads in people's places, all with the Wi-Fi built in and the call service built in. All you have to do is touch one button, connects you to your doctor, connects you to your peer advocate, to your friendly visitor. So we have started doing that kind of a service. Also in partnership with our provider partners, it's interesting. Some people still want to go to the doctor's office but don't want to go inside the doctor's office. So we've been doing iPad drive-throughs where you come in a drive-through, we give the person an iPad and they see Eric, but they are sitting outside in your parking lot. So we have tried all those things, and that's where we are seeing the momentum building up. I want to finish with a little cool story. As these needs were emerging, we were getting calls from our members to say, hey, I want to see my doctor online. I don't know how to do it. I'm confused by this portal stuff. So we started a new benefit. We call it Health Tech Line, which is a help desk for our seniors. So you can call in and our help desk will help you set up your account in MyChart or your account for this portal and that portal, so we can take that burden off you so you can associate with that. And the first call that we got was from this 90-year-old gentleman who said, I want to see my doctor on video. I have an iPad. Can you help me? And so my help desk person, our help desk person, helped this person. It took us 90 minutes because we had to help them set up an email account. You didn't have an email account. So they can then create the account in the MyChart. But that made it happen. And so I don't want people to walk away thinking we're just focused on the older adults who want to do it. Our 85-year-olds, our 90-year-olds, I looked at the adoption, and we have 300 people who are 100-year-old. Even they are adopting, and maybe it's their caregiver who's doing it for them. So I don't want people to walk away thinking, all older folks are not interested. A lot of them are interested. And for the others, they may not have resources or access to it. And that's where we have to build it.
No, that's perfect. I love that story for two reasons. One is support is literally the thing that makes technology succeed or fail. It's not obviously there's a value in the quality of an iPad or a tablet, et cetera, but it's the human part of all of the rest of it that's really, really important. But the second thing you said that was very important is that even the older ones want to do it. And in fact, that's what I'm suggesting to us, to our Health Impact audience is, don't just design for the 62-year-old because they may have lots of help around them. Go to the 70, 75, 80-year-old one, not because you're going to have millions of those guys there, but if you can design for them, guess who else can use it all over the place? And so when you look at this isolation problem, isolation often occurs obviously due to lack of human touch, but human communication is enough either as well. Like that, why does that phone call still work? Because the communication part does help with isolation. Eric, any comments on the isolation part? To me, that's a serious problem that we're probably going to pay for over the next couple of years as we find out what the subsequent comorbidities are with isolation. Anything specific you guys are doing from a tech or other perspective?
Yeah, so I think what the pandemic again has exposed in its rawest form was a social isolation, right? I think because of this fear of going out, we did a really good job of letting this entire nation know that you shouldn't go out. You got to wear a mask. Physical distancing. Don't come in. And we've seen some and heard about adverse consequences, right? Patients having heart attacks, strokes, and because they were terrified of going into the ER and contracting COVID. And I think so. Even pre-pandemic, right? I think that's one of the best things about our PACE program is that it's built and it's configured to address social isolation and prevent it from the get-go. So, pre-pandemic, it was participants would come into a PACE center 1 to 3 times a week, depending on how many, what their comorbidities or current situation was. If they're rehabbing from surgery, they may come in every single day for physical therapy, right? But there's also recreational activities. They're able to socially engage with other participants, with the staff, and it's a very high touch environment. Obviously with the pandemic, a lot of that was taken away from them, right? And, we've had to build up to 20% capacity or 25% capacity where we bring them into the center. They're transported to see specialists or to have imaging studies done, and then they're brought back to the center. So to address the social isolation, specifically with regards to the pandemic, it was a lot of high touches, right? Daily touches. Somebody from the interdisciplinary team was calling each participant on a daily basis, right? Whether it's a physical therapist, social worker, it's the physician, him or herself, right? Somebody is calling. And it's phone visits, it's video visits, it's bringing them in, and you have to be able to have the constant communication to then assess, okay, this participant's beginning to get depressed, right? Because if you don't have that constant dialogue, you're not going to be able to see, oh, I see the trend going downward now. And now this is a candidate because this patient's high risk, this participant's high risk of depression and worse outcomes. we got to bring him in, or we got to schedule her to come into the center and to start engaging with us again. So there's that. There's also, how are we going to engage with, there's just physical activity classes where they're sitting in a chair and they're doing physical therapy, or they're just doing dancing classes, right? And really just getting their body moving and blood pumping. And, that's a form of exercise. And how can we offer that on a group video visit level, right? So that's, one of the things we're working on, because you have to be able to offer that, right? If a participant doesn't want to come in, or they cannot come in, right? You got to be able to engage 15 participants. You're going to have a camera on the instructor and maybe another camera on the participants in the center, so they can see that, and you have this engagement like we do here with HealthIMPACT right now.
No, perfect. So we're going to open up our audience to Q&A for you guys here now. But I'd just like to give Ramala the last word. From a insurance plan perspective, you guys have a different way of seeing how you can spend money on your seniors, right? Because you're able to do that. What suggestions do you have for providers to work with you guys so you can try to offload some of their costs and other things? Are there any special plans during or post-COVID to do more collaboration with providers because of what you've learned on the plan side?
Yeah, so we always continue to work with our providers and advocate on their behalf and our behalf. And I think advocating for our members, regulation is a big deal. So let's make sure, we don't go back to the old way of doing things from regulatory perspective. So Eric said right now, audio visit, non-face-to-face visits are getting reimbursed for the providers at the same rate as anywhere else. Let's take away all those regulations around, you cannot code for certain visits when you are doing over the phone, because some people still want the phone and some people want video. So let's do that. So we want to continue advocating on their behalf and work closely with them. The other thing I would like to say is, as a plan, as a Medicare Advantage plan, we can also offer benefits. I think it behooves us not only to provide this kind of technology for those who want to adopt them, but for those who want to but cannot because of lack of Wi-Fi access, lack of device access. Let's get technology to them. Let's support them with technology. Maybe, crazy idea, let's, in our supplemental benefits, give them Wi-Fi access as one of the social determinants of health needs, just like we do food or things like that. So those people are also very well supported with it. And last but not the least, let's also, break our barriers, because if we looked in our data, the people who speak different languages are adopting it. People in different age bands are adopting it. People in different zip codes, even those zip codes that are socioeconomically disadvantaged, are still adopting technology. So let's keep working at it and keep that human touch still going. I really love the idea. We do something called virtual senior center at home, which just does that, Zumba classes at home. So let's keep using those technologies to build those human connections.
No, I love it. And with that, I want to thank Drs. Batra and Lee, and we're open for questions to the rest of the HealthIMPACT audience for the next 10 minutes. Let's take it away. Thanks again, guys.
Thanks, Shahid.
Thank you.
Okay, great. Eric and Ramala, you did a great job during the primary part of this, and now we'll pick up some audience questions. We had a really good discussion this morning, right before we started HealthIMPACT, around caregivers, family members, and how much influence they have both on care as well as the experience of the care that they have at the various places where they go. I'd like to just start with that as the first part of the question, and maybe Eric, talk a little bit about how, when you deploy your tech in the service of seniors, how much can you account for caregivers, family members, et cetera, with the technology that is available today? And what would you like to see improved to account more for caregivers and care providers? And then Ramala will bring you in as well. So Eric, take it over.
Yeah, thank you again. Great question. So I think with the tech, as you deploy to seniors, and you want to make sure they have a good social support system at home. I think that's one of the keys to being able to start, because you want to start small, and if you do something big bang, it's going to be really hard to provide that high touch, personalized kind of support and services that you need for that each family or seniors with their family members will need to be able to feel connected. So, again, with our PACE program, for example, we'll have adult children that'll be the proxies for the PACE participant. They could be in Northern California, they could be in Nevada, right? They could be completely across the country, and that happens, right? And so, if you're going to introduce that, well, let's make sure they have social support. Let's make sure that we're able to keep those family members in the loop. So the tech has to be able to accommodate that, whether it's a patient portal and you're allowing proxy access, or if it's going to be a tablet that you're introducing to the participant that has really large icons that makes it easy to see, okay, this is what I need to see for my daily calendar of activities for the day, so I can be virtually engaged, right? Here's how I connect to my provider so I can see them for the video visit. And then you want the proxy or the adult children or the family members, whoever it is, to feel connected and be able to also engage and feel like, okay, I got the updates. I know what's happening with my loved one. And that's how successful tech is rolled out.
And Eric, when you are looking at as a buyer of this tech and deployer of this tech, are you feeling in general that the family caregivers, these proxies, are being accounted for in the tech? Or are most technology vendors kind of like either apathetic about it, they don't really think about it, they kind of like just say, okay, the family members can just reuse accounts, like just share usernames and passwords? What do you normally see on an average basis?
I think it's incredibly complicated, right? Because I think the legislation varies from state to state. So I think if you're going to try to introduce it into a state like California, where there's lots of legislation, let's put it that way, accounting for that as part of your build requirements is challenging, right? But I think I'll leave it at that, because I think that's really more of how can you accommodate for the 80-20 rule, right? But then not leave the 20% behind, and be able to be flexible with getting those loved ones to feel connected as well.
Sure. And that was Eric's really nice way of saying, hey, Shahid, you guys as software engineers are not really thinking through all of this. And please give me much better software that realizes that not just especially seniors, but also think about it, kids or others that do have, a family who might have a spouse who takes care of another spouse. This is one of those pet peeves that I have actually as technologists, so I'll just badmouth us, because Eric, I was hoping that you would badmouth us, but you were too nice to do that. So we have to remember that as we're designing for these seniors, one of the reasons we're saying design for them is there's some very special things about them, and this proxy requirement and the family connection, caregiver connections, et cetera, that are not common on the other demographics are very common in this demographic, and we have to take care of that. And if you do, it makes your tech actually more valuable, because now you have more use cases, you have more users on the system. So it is a little bit more work. So getting it right is non-trivial, but we can't forget about it. And that's really what I wanted to call out. Ramila, what do you guys see both on the business side as well as on the tech side from the plans? You already deal with this, right? You have that a Medicaid a Medicare a senior is rarely completely alone and without any connections to anybody. How do plans see tech handling this kind of proxy requirement? And you don't have to be nice like Eric. You can actually say, if we're not doing our job right, let us know.
I think for us, we very strongly believe in supporting the caregiver. We very strongly believe in something called the co-design phase and human-centered design. So we have done a lot of work ourselves as we are deploying these tools and technology in bringing in our members and their caregivers. We have a member advisory panel. We have a caregiver advisory panel. And wherever possible, we try to incorporate that in our workflow. Obviously, we are not the creators of technology, but we have been giving feedback to your points to ensure that we have access for our caregivers. So to Eric's point, we are trying to capture the information to figuring out who is the caregiver. That's the first thing for us. And how do we capture that information? And I'll tell you, we share like EMR of sorts for a case management system. There's no clear box that identifies where we can capture systematically to say who's the caregiver and to be able to target that caregiver. But I hear the portals, for example, EMR portals and all, you can create a separate account for caregivers. So we've been trying to give that kind of feedback, especially as it pertains to older adults. I cannot say with a straight face with general counsel playing in my head that I can tell them to start sharing it with the same password with their own caregivers. So that's something we are building it as we are thinking about workflows and deploying things.
Yeah. No, that's a great way. And again, Ramala was actually too kind. Not including family caregiver or other information is like not asking someone's last name. Like if you just ask for somebody's name and you don't know what's the first name, middle name, and last name, it is that level of silliness in the year 2021. And we need to think about that now. And to be fair, Ramala can't say it because obviously she has GC general counsel things to worry about. I have no such fears. You're going to have enormous numbers of family caregivers, et cetera, that are sharing accounts. Why? Because people still need to solve their problems, right? So yes, we're never going to say, hey, it's okay to share accounts. I'm a cybersecurity guy. I would never say, yeah, it's okay to do it. But what's the inverse of that? Yeah. If I don't do it, do I just leave my parents out there because I don't want them to share their accounts? Of course not. That's insane. Yeah. And we're going to have to do it. And this is why it's so important. Remember that there are other users along with the patient. And if you don't take care of them as a software engineer, product designer, quality assurance, product manager, shame on us, right? I mean, it's just literally it's the year 2021. What's holding us back? It's certainly not the tech. It's not like we can't add some more fields, et cetera. It's because we don't think about it. And that draws us a little grief as well. So with that, did anybody have any other things to add on that? Otherwise, I'll go to the next question.
Yeah.
No? Okay. So the next question that arose also related to this is, as seniors begin to go into remote patient monitoring, and we talked a little bit about the audio and other pieces, what are you guys doing with respect to pulling seniors together that have similar kinds of conditions to use technology so that you can get out of the way? And so Eric, obviously you're on the healthcare provider side. Just like we bring a therapist together, we bring them to a church, or we bring people to a school, you have 30, 40, 50 people in a room, and you have a facilitator, but really people are helping each other. We don't really have the virtual version of that, but it would seem like seniors would love to get that kind of capability, and that would trickle down very easily to almost everybody else. So the patients like me model, but for true care providers where the comorbidities of these group members are similar to others enough where they can help each other rather than leaning on nurses and doctors and clinicians all the time. Because once you have comorbidities, chronic conditions for a long time, patients actually can help each other more than doctors can. So thoughts there?
Well, so again, that's a beauty of the PACE program, right? I think I talked earlier about the pre-pandemic situation with PACE, but even during this pandemic, the interdisciplinary team is key to connecting the PACE participants with each other. That's how they form friendships, right? And I think that's how they're able to stay in touch with each other. So during this pandemic, there's been an interdisciplinary team member that's been calling or doing a video visit or making home visits, right, to each PACE participant on a daily basis. That's that's, I think we have almost 3,000 participants. So that's no small undertaking. And so for our PACE staff to be able to do that and continue to have these high touches with these participants, and that's how when someone's beginning to feel increasing depression or worsening depression and beginning to feel that worsening social isolation, hey, we got to bring this participant in, right? But then I think as we start to get our participants vaccinated, right, and I think we're going to start seeing an increase of participants allowed back to the PACE centers. And I think we're going to be able to go back to this new normal, right, as lots of people like to say, of being able to engage, have the participants help each other again. I think they've been able to call each other, but have them engage with each other again and help each other, as well as interdisciplinary team members to be able to help as well. Awesome. But it's going to be a new hybridized kind of model that'll happen.
Yeah, that sounds great. So we are unfortunately out of time, but this was terrific. Thank you so much for sharing all your knowledge about the seniors. And remember, designing for seniors doesn't mean exclusively. It means designing for seniors so it trickles down to everyone else. And with that, Ramala, thanks so much for being here. Eric, thanks for being here. And please join us on our next session that's starting right now. Bye, all.